We're live and you can start.
Okay, thank you. So very good evening, everyone. It again gives me immense pleasure to welcome you all for the day two of Gurukul continuous academic program for the postgraduates and for our fellow colleagues. And then yesterday, I think, yes, we had a lot of discussion on the SGL2s, urinary tract infections, self-monitoring of blood glucose, and then we ended up with and diabetes. I think today it's going to be a complete debate. I think we all always have our own way of practicing when it comes to type 1 diabetes and when it comes to management of thyroid disorders in pregnancy. And then for that, I have Dr. J. Srikant, who is our chairperson chairing for the session. It gives me immense pleasure to welcome Dr. J. Srikant. He is the head of the Department of Internal Medicine, Apollo Hospital, Jubilee Hills. Welcome you, sir.
Thank you.
And then let me just brief you about Dr. Jay Srikant, a very good friend of mine, a great academician, professor, teacher, and an artist as well. So there is all what you can look for when you are looking at your seniors. So before going on to the session, Minto, can we have the video, please? So this is where all it started. So thank you so much. And then we started in February, where the FDA organized its second event, and where we started our Gurukul. So we had three modules, and this is the final and the end module. And then yes, we had Dr. Jay Srikant with us from the beginning. And over to you, Dr. Jay Srikant, now.
Thank you, Dr. Faraz. And it's a real privilege, I should say, to be associated with such a great attempt and started by you. And then it's going, I'm sure it's going to go great guns. And I wish the entire project, we were just discussing about the role of vaccination regarding COVID. And then Faraz was just informing that he's going to start the phase 3 trials. So great job for us. I wish you all the best
Thank you so much.
in all your future endeavors, and I am with you always.
Thank you.
And
Minto,
tonight,
can we have the slide?
tonight's
Please, sir.
program is again extremely interesting, and we have two eminent speakers, Dr. Amarnath and Dr. Swaraj. Dr. Swaraj,
We'll have Dr. Amarnath first.
first, is
Minto.
it? Okay.
Yeah.
Dr. Amarnath Kulkarni is a senior consultant pediatric endocrinologist. It's something which is a very specific entity, and then I'm sure at the end of the session we are going to have a lot questionnaires. He is specifically trained in insulin pump therapy and skeletal dysplasias. He is having almost 10 years of experience in pediatric endocrinology. He was awarded the best outgoing student of Nilofer. So he happens to be my from the same college, the Usmania Medical College. So we are all in the same family. And he was the organizing secretary for the Pediatric Endocrinology Conference held at 2017. and he happens to be the first pediatric endocrinologist from Telangana to start continuous glucose monitoring and blood ketone parameters in children. So he has conducted the first national level OSCE pediatrics workshop in India. So a warm welcome to Dr. Amarnath. He would be enlightening us on type 1 diabetes. Am I right, Dr. Faraz? I think that is a topic which Dr. Amarnath is known
Yes.
for.
Oh, yes, yes.
And he's going to elaborate, and then we are going to have quite an interesting session. Welcome, Dr. Amarnath.
Thank you very much, sir. Srikant, sir. Thank you very much, Dr. Faraz. We have shared maximum sessions both together, Dr. Faraz and me. And sometimes he was a moderator and chair. I was speaker. And sometimes I was moderator and he was speaker. So it's just like a family friend. So हिंदी में बोलना है तो चड्डी दोस्त बोल सकते हैं. So we always
Correct.
feel very comfortable zone to share. So, in spite of my hectic practice, uh, first of all, I would like to congratulate the Gurukul, and we wish and we pray for the expansion of Gurukul, and I am grateful to the Gurukul. So, recently I was been elected for executive council board member for the ISPA, that is Indian Society of Pediatric and Adolescent Endocrinology. So that was all your blessings, I can say. And I will be there for another 2 years in Executive Council. It was a great thing. And I'm running 3 free diabetes clinics in Hyderabad. All of you should know, below 18 years, any diabetes child, everything is free in Ramakrishna Math and Vivekananda Health Center. So including consultation, insulin, we have including Lantus insulin and Actapid also, like basal bolus regime below 18 years, and glucometer, everything is free. So also in Mehboob Nagar, Bidar, and I am speaker for more than 10 international conferences, author for many textbooks, and I am also visiting Karimnagar, Mehboob Nagar, and Bidar. So any one of you are there, you can utilize it. With this introduction, we will go to the crux of ambulatory management. Ambulatory management means without admission, how we can manage the type 1 diabetes patients. Okay, it will be an interactive session. I ask all of you to interact with me. Okay, so what is World Diabetes Day? So 14 November. So it is same as your uh, Children's Day. So I call all diabetic children as not patients, but can anyone tell what is the best name can be given to the diabetic kids or the adolescent? Even we can call adults also. I call them sweet kids, sweet children. So you can understand they are so sweet. They go to picnic, they enjoy life, they go to what we call movies. They can enjoy anything in this world. Now we have got very good insulins, very good continuous glucose monitoring, and now insulin pumps available, advanced insulins available. With this introduction, so first we'll have a small quiz type of thing. Anyone can answer. We are able to see some stones in pancreas. What is the diagnosis? You can either type in the chart box. So this is a fibrocalcific type of pancreatic diabetes. It's increasing. So here you are able to see something on eyelids. What is this? External hardiolum, chalazion. This indicates very bad control of diabetes. And here you are able to see the acanthosis nigricans. This is very important. So any obese child with acanthosis nigricans indicates the insulin resistance. So again, we are going to discuss the 3 important factors which are important in diabetes control: is diet, exercise and insulin. You are always concentrating on insulin and oral hypoglycemic agents in adults, but in type 1 diabetes, there is an equal importance to the diet and exercise. Don't neglect that. So coming to this is the ketone meter. It's a very important. More than 3 milliequivalents we call diabetic ketoacidosis. Less than zero point 0.6 is normal. So now an advanced era. So blood ketones are replacing the arterial blood gas analysis for your DKA management. So all of you should start using the blood ketone meter. The cost is only 100 to 125 rupees. This patient from Indonesia came for one of the famous hospitals in Hyderabad for heart surgery, and sugars were little high. They thought of maybe stress, but uh, to her bad luck, she was diagnosed as type 1 diabetes, and luckily mother was having type 2 diabetes, so she understood. She was giving her mother insulin, so it was very easy for me to counsel. So again, the kidney involvement, MODY type 5 can be there. So you can see how beautifully these children are enjoying in our one of the camps. So how beautifully this angel with this flower. So we can say I enjoy all diabetes children and kids. Once you know this, so that sweetness and fragrance will come to you. So again, this is the inauguration of 3 diabetes free clinics in Hyderabad, this Mehboob Nagar, and this is a class in Bidar. So again, quiz. Can anyone tell what is this? Please, you can answer randomly. This is a rapid fire. So you're able to see the oral thrush. So you should act like a CID. What is mean by CID? C means look for consciousness. Any type 1 diabetes coming to you. I means source of infection. D means dehydration. So act like CID in type 1 diabetes. You know this is a urine ketostics. It will take 12 to 48 hours to disappear from urine when blood ketones are absent. So it's outdated. Previously this is commonly used, but still it's a great help at PHC peripheral level where blood ketone meter is not available. So all of you should keep this either glucose with ketone meter or ketone meter. So this is a diabetic chiropathy. So complication. This already we have discussed the ketone meter, acanthosis nigricans. We're able to see the cataract, or sometimes we can say the crystal, especially cystinuria. You are able to see something here. What is this? Vitiligo. So you should think of autoimmune polyendocrinopathy, chronic complication of diabetic dermopathy. So associated with deafness, you should think of Didmot syndrome or deafness with diabetes insipidus and diabetes mellitus. Again, same chiropathy. Here you are able to see alopecia. So this is a common autoimmune conditions associated with type 1 diabetes. All these things are very important. Why? Because in adults, as the age increases, the brothers and sisters of type 1 diabetes increase. What is called brothers and sisters? The most common brother or sister is the autoimmune hypothyroidism. So that is called type 3A polyendocrinopathy. With this introduction, we'll go further. 10% of all diabetes is type 1, and we know in worldwide there are 2.858 billion type 1 diabetes are there, and India ranks the number 1. So there are 1,84,100 children and adolescents with type 1. So every year 21,300 newly diagnosed cases we are seeing. So without wasting much time, what I wanted to say is whenever the patient is coming to you, most of the times either stage 5 or stage 4 of diabetes. So how stage 3 to stage 4 diabetes they are presenting to you with weight loss, chronic weight loss, and pain, abdomen, vomiting, respiratory distress with diabetic ketosis when no C-peptide is present. So around 30 to 50% of patients will come to us with diabetic ketoacidosis. So we know what are the types of type 1 diabetes. Previously we thought only autoimmunity, but now there is a entity called non-immune type 1B diabetes. And what are the antibodies available? Isolate cell body, anti-GAD antibody, IAA, insulin auto antibody, anti-isolate and antigen 2. So please note, most commonly we do anti-GAD antibodies. It is present only in 60% of cases, not all cases. And in India we found zinc transporter antibodies are increasing. So if you do antibody test, it will help. But the total panel, if you do, it will cost around 10,000. Only anti-GAD cost around 2,000 rupees. So whenever there is a doubt, there is a terminology called type 3 diabetes or type 1.5 obeys with mimicking like type 1 diabetes. There it helps. Again, C-peptide has to be done at onset and after 6 months of onset of diabetes to differentiate between the type 1 or type 2 or atypical diabetes. So coming to the definition, all we know more than 200 milligram anytime and the fasting more than 126. Recently HbA1c also is proving very good, more than 6.4. Please note that if suppose daily I am eating more rasgullas and all sweets for 1 month, my HbA1c is increased. So we have to take the history of increased sugar intake. So these are the stages. Stage 1, 2, 3 already we have said. So stage 3 commonly present to us. Otherwise, there is no role of OGTT in type 1 diabetes. Already sugars are 300, 500, sometimes unrecordable. We have seen up to 3000 sugars. You can ask how. So we have to send to the lab and we have to do double dilution technique. So how to differentiate between type 1 versus others? It's a very common confusion happens in adults. So that's why we have kept acanthus nigricans absent in type 1. BMI, body mass index, is more in type 1 diabetes. Most of the times 90% it is normal BMI, but now at least 10% of type 1 diabetes seen with increased BMI. So it can be overweight or obese. Please think of type 2 diabetes. Family history commonly present in type 2 diabetes. In other types, family history only 1% chance. If one sibling is having type 1 diabetes, the other sibling getting is only 1 to 5%. Antibodies are uh, positive in 60 to 80%, but in type 2 diabetes and other diabetes at least 5 to 10% can have. Please note, when normal population up to 1 to 5% can have high GAD antibodies, so it's a protective phenomenon. So C peptide levels already we have said. So C peptide levels initially may be normal, but ultimately it will decrease. So if it is normal for some time, we diagnosed that type 1 diabetes with decay, but after some time the insulin requirement will come down to just only 20 to 30% of the total dose. So how our diabetes can mimic other conditions like pneumonia? They have acidotic breathing, diarrhea, viral meningoencephalitis. When I entered my DCH, first case in to PICU, then he said, let child pass the urine, then we will send. So morning I went for the ICU. By he checked ketones. Maybe God has decided in my DCH in Usmania Medical College itself I should become an endocrinologist. So that day I remembered mimic like any other medical condition, asthma, surgical acute abdomen is because of spasmodic vasoconstriction, malnutrition, 10 kg weight. Please note, record daily weight and urine ketones or blood ketones in all admitted diabetic patients. So increase in weight itself is an indication for very good treatment. So confirmation of diagnosis already discussed. A1C, urine or blood ketones more than 3 indicates the decay. ABG, we know mild, moderate, severe 7.1, 7.2, 7.3. Mild, moderate, severe. GRBS, again we have to confirm the decay and glucometer for diagnosis lab is better. Then do electrolytes. It can cause hypokalemia, hyperkalemia, and normal. It can cause kidney failure, acute kidney failure due to pre-renal failure. High lipids and total leukocyte count. This is a very important thing. So you think that dyslipidemia is there? No. So only after recovery you do the lipid PLC. Again, they may not have fever, but you have to do blood and urine calculation. Especially in all first to do fasting C-peptide, GAD65 antibodies and other antibodies. Anyway, there is an increased chances of zinc transporters. So these are the essential things any diabetologist, especially for type 1, they should be uh, date of opening, and it will expire within 3 to 6 months based on the type of these strips. So after that you cannot use, and it hardly costs 6 to 8 rupees, which can save lots of lives. My professor was awarded the best clinician award by European Society of Pediatric Endocrinology. He was practicing in CMC Vellore. So at least 10 to 20% of patients coming from Kerala, they used to die in the uh, train. Why? Because physicians are afraid of treating. Please note, this is a very important point, take home message for you. So any type 1 diabetes diagnosed, immediately you have to give insulin at least zero point 0.1 to zero point 0.2 units per kg of human actrapid. Suppose from 500 kilometers they are sending to Hyderabad, overnight child may go into dehydration, decay and have death. So please give zero point 0.1 to zero point 0.2 units per kg of human actrapid. This is a life-saving drug. All physicians should have their in clinic in refrigerator. Never deep freeze it. Okay. So transitional care. So 8-year-old girl was referred to endocrinologist, newly diagnosed, unhappy, don't want to agree. This is a common thing in type 1 diabetes. Type 2 means they will agree because only tablets. So any child or the adolescent or adult, they will not agree type 1 diabetes. So it's a very difficult thing. So it's a fear of revealing. So 90% of physicians or pediatricians, they never tell the diagnosis. They send to us. Do not use bad words. So one of the doctor used, it is just like a bomb, releasing the bomb. जैसा नदी रहता है, नदी में पानी बहता है, ऐसा तुम्हारे पूरा ब्लड में ग्लूकोज ज़्यादा हो गया. Don't be using the scary words. I use sweet kid. Your child can be normal. They can live like anything. If they are using 2 times, so 2 mosquitoes are coming and biting your kid morning and evening. If they are using 4 times insulin, I said daily 4 mosquito bites will come. Your child will be as normal as any other kid. So this is a very important thing in type 1 diabetes. This is how it differs from the other type 2 and other types of diabetes. So give hope. You can child be as like as normal. So most of the physicians and pediatricians, what they are doing, they are putting in child into jail. So one of my patient, when they are cooking, they used to cook different per patient and mother and father. This is wrong. So same food can be given. 95 to 99% of what we are eating can be given. Okay. You know, Wasim Akram has the type 1 diabetes. There's so many Olympians they have. So we give full hope they can live normal life. So this is the most important part of my talk. Please concentrate here. So if you know this, this is called crux of treatment of diabetes. This is my topic name itself. So crux. So if you are perfect in diet, exercise, insulin and orbis monitoring, and education and timing. So most of now COVID is there and nobody is going to school or job. They are eating at 11 o'clock their breakfast and all. That is not correct. So they have to maintain the timing. Suppose I am telling to take the morning breakfast at 7 o'clock, maximum 7:30 or 8. So coming to the diet, there is a regime called 6 times regime. Please note this, a very important thing in diet. So three major meals: morning 7, afternoon 1 p.m., evening 7 o'clock. So three major meals of full stomach they have to take. Preferably salad should be taken, and three mid-meal snacks at 10 o'clock in the morning, afternoon 4 o'clock, and also night 10 o'clock. Please note, night 10 p.m. snacks is very very important in type 1 diabetes, because otherwise child will be going for the what you call the nighttime hypoglycemia, because 10 hours there is no meals. So that is the reason 10 p.m. snacks is very important. Night 10 p.m. sugar should be preferably more than 100. So this we have completed the diet. So preferably 3 to 4 times they have to take fruits and vegetable. So I ask them to give two boxes, one box with fruits with vegetables. So preferred fruits, already, orange, guava, papaya, apple, pears also very good fruits. So all other fruits they can eat except sweet fruits. So then coming to the exercise. So this is a very important role, at least 15 minutes to half an hour. If it is a running, just 1 hour to 2. Without that, they cannot have very good control. So coming to the insulin, so most important part in adolescent at least 10 to 20 days. So we ask them always take in front of parents. It's a very very important. So we always prefer the 4-time insulin, that is called basal bolus regime insulin, like Largine, Besac, Degludec, so any one of them. And 3 times, morning 7, afternoon 1, evening 7. 3 times we give the short acting insulin, either Actrapid, Novorapid, or now fast acting aspartate. So RBS monitoring we call 7 to 8 point monitor. That means pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and one in the early morning, preferably between 3 to 5 a.m. to detect the dawn phenomena or somatic phenomena. So these are the insulins available. Already we know the most advanced insulin is the fastest acting Fias. So pre-critical within 4 minutes it acts. Like now it's an advanced thing. Within 5 minutes when child or adult take the insulin, just start eating. So we have other three like aspartate, glulysin, and lispro. This can be taken within 5 to 15 minutes. And most commonly used already we know Actrapid. So other things are like glargine, detrimer, and we know only 30-70 or 50-50 use. So very rarely we use in adolescents or children. Adults commonly use. So this is the insulin which causes maximum hypoglycemia. So we know already this, the Lantus and all. So just here, most caution thing we are telling: use U100 for the U100 type of insulin. You see Actrapid 100. Again U100 also two types are there. So 50 units and 100 units. So we have to know this is a very color code of the insulin. So U40 is red color, black is U100. So this is the Actrapid. 40 units Actrapid is different, 100 units is different. All pens have 100 IU per ml. You should know 3 ml one pen. So this is a common thing. Most common cause of hyperglycemia in adolescents or adults with type 1 diabetes is the lipohypertrophy. They are taking at same place. That's wrong. So best will be 45-degree angle, the subcutaneous insulin or the intradermal. So don't give 90 degrees. This is so only in where the less fat is there, then we can use 90-degree for the pens. So this is a lipoatrophy. This is uncommon now. Porcine insulin it was common. So answer these questions again. We know already pillars of diabetes. 4, diet. So when there will be hypoglycemia, if they are doing fasting. So this is very important. They should not do fasting in type 1. That's why it's called no fasting and no feast in type 1 diabetes. So try to avoid. But now with advanced type of insulin, this is also possible. They are taking more the sweets, it can cause exercise. So more exercise, we have children like they played a lot, they went to wedding party or something, and night they got the fits. So it's very important. Next is the common is fever. Illness will cause most of the times hyperglycemia. So grandmother tells, oh, child is ill, don't give insulin. Wrong, you have to give more insulin. Again stress, exam stress, other admissions and all. Loose stools, they have hypoglycemia. So treatment, already we know hypoglycemia management. Immediately sugar check and give 15 grams of glucose or glucon D, even fruity or fruit jam give, and within 15 minutes it will be more than 100, and give snacks. And hyperglycemia, we have to increase the insulin dose, short-acting insulin, either Actrapid, Fias, Parnovarapid, or Apidra, by 10% of total dose every 3 hours we have to give. So that my all patient, we have 500 patients of type 1 diabetes, they never get admission for type 1 diabetes single time, only first admission. So this is a very important education. So again a small case scenario, old 12-year girl, severe pain abdomen, presenting respiratory distress, cough, lethargy, GRBS high. Diagnosis already we know, DKA. So most important investigation is your the urine examination for ketones and glucose and blood gas. CNS complication, rule out your cerebral edema. So already we have told this without wasting much time. Two common types of insulin regime we know already. Twice daily split mix regime. Noted in adolescents and children. So means Actrapid and Insulatard we use separately. And always it's better to give the one more shot at afternoon. The 3 times is preferred over 2 times. This is an old regime twice. You are using Mixtard 30-70 morning and evening. But for better control, afternoon 1 o'clock, please start using Actrapid. You will get better control when you are using Mixtard or Novomix, the advanced insulin. So best will be basal bolus regime. Give one long-acting insulin. The best will be again Degludec, but costly, 1200. Now Besaglar or Glargine we can use night 10 o'clock, and 3 times breakfast, pre-lunch, pre-dinner. This is the best regime to use in type 1 diabetes. So here we are calculating simple 40 kg child requirement is zero point 0.8 units, but puberty means requirement will be 1 to 1.5 times the insulin. Coming to basal bolus, we think that the requirement would be around 30 units. If you take 30 units requirement, divide into 5 parts, 6, 6, 6. So 30 divided by your 5. So morning 6 units of Actrapid or the Novorapid, 6 units of Novorapid in the afternoon, 6 units of Novorapid in the evening 7 o'clock. Night 12 o'clock, 12 units of your Glargine. Suppose child is pubertal, you have to increase. The requirement is not zero point 0.8 units per kg per day. The requirement is increased. So you have to give the 40 units or even 50 units. If you take 50 units, 10 units 3 times, 1 is to 1 is to 1 and 2. So divide into 5 parts, 1 part for the pre-breakfast, pre-lunch and pre-dinner, like this. So acute complications we know already, we have discussed. We are coming to the end within 5 minutes. So that is the hypoglycemia and hyperglycemia. Please note that. So HbA1c is important. Try to maintain between 6.5 to 7.5. So now the HbA1c is becoming absolute. The best will be continuous glucose monitoring. That is the time in range. Only 5% of time should be less than 70. Less than 70 we call hypoglycemia, but ideally it should be less than 54. So less than 40 called severe hypoglycemia, which has fits and also the coma. So serial monitoring is important. See, initial diagnosis 10, but now it is 7.5. So please keep a graph. So sick day guidelines, always check your glucose and the ketones frequently. Use carbohydrate drink if it is loose stools, and don't use carbohydrate if it is high sugars. Check your ketones, contact your healthcare personnel. It's a very important. Every third hourly, check sugars and ketones. So insulin pump, this is an advanced thing, and it's continuous glucose monitoring you are seeing. So now we have the automated insulin pump. So if low sugars, it itself will get off. So every 3 to 4 days, you have to change the cannula. So this is the education book. So again, without wasting much time, we are going for the next part, how to adjust the insulin. So suppose 10 o'clock sugars are high, that means we have to increase the morning actrapid or the novorapid. So here we are using actrapid plus insulatard. So when is the peak of your short acting insulin and long acting insulin? This is very important for dose adjustment. So we don't have a time, but I shall tell you. So for short acting insulin, FIA peaks within an hour or 1.5 hours. Suppose 7 o'clock evening you have taken the dinner. So FIA peaks at 8:30. So check sugars at 8:30. Suppose you are taking actrapid as your insulin, the peak is at 3 hours. So 10 o'clock insulin. I have taken 7 o'clock 10 units of actrapid, but my sugars are 500 at 10 p.m. So I should increase my 10 o'clock, 7 o'clock actrapid insulin. Same for the glargine and your Tresiba. You have to check in the early morning insulin, 7 o'clock. If sugars are low, means you have given more insulin, decrease. So this is how we control. This is a rule of 500 for Humalog and Novorapid. This is called insulin carbohydrate ratio. So we divide 500 by the total daily insulin. Suppose 500 divided by 5, we are taking uh, 50 units of insulin. So the insulin carbohydrate ratio is 10. That means uh, 1 unit covers the 10 grams of carbohydrate. So insulin sensitivity factor. So rule of 1500 divided by total daily insulin. That will 1 unit of insulin. How much the glucose it will decrease. So this is very important who are taking the 4-time insulin and also the insulin pump patient. So now we have an advanced IPDM model, that is personalized diabetes management. So if you start using the glucometer or the CGM with cloud based, suppose your child is somewhere in Karnataka, I'm going to be there. He has checked in AccuCheck the instant. So I'm going to get in my application sugar is 40. So from here I can advise. So this is advanced technology we all can use. So this is a significant improvement after using the IPDM model. We are able to see HbA1c is decreased. So these are the advantage of IPDM model. So all my patient for even CGM when they use, so they used to send the daily WhatsApp value, and I used to adjust the insulin. So not like patient is coming after 1 month and you are adjusting. No, instantly you have to adjust in type 1 diabetes, because frequently dose changes in adults and adolescents. Whenever child is having puberty, menarche, so we have to increase the insulin. Again, have other types of diseases like Addison's disease, autoimmune hypothyroidism, celiac disease. We have to decrease the dose because they will cause hypoglycemia. So they can have marathon. So this is the last slide of my talk. So any diabetes child, what we need to do? Compulsory they should be informant. Parent should be there. Sometimes they don't take insulin, they act like that. Otherwise they are taking at same site insulin, that is called lipohypertrophy. So ask parent or someone should be there. Check the weight, there should be steady increase in weight. So 3 to 5 kg increase every year should be there. Height, look for the growth, very important. Chart and growth chart in adolescents. School performance, 90% of my children, they come first in the class, they are all first class students. At least 3 to 5 patients, they get 10 out of 10 in 10th standard. So look for pubertal status. As already we have discussed, the requirement will be more and chance of depression is more. And you should write follow up after 1 month for irregular patient and regular patient 2 months. Check for blood pressure. Uh, it's for microvascular complication. Injection site should be checked. Ask for the Namaskar sign or Namas sign to see for chiropathy. Look for liver, indicates the other types of diabetes. Thyroid function test should be done for complication after 2 years of diagnosis. Urine for microalbumin, fundus for retinopathy. So take home message, most important in type 1 diabetes is love and affection towards the patient is the key to success. We need to spend at least 15 minutes to 45 minutes. Initially 45 minutes and repeatedly when they are coming 15 minutes. Give maximum hope. So we see type 1 diabetes जो lifelong रहता है problem कुछ भी नहीं normal रहता है. All my type 1 diabetes are better than other children. They eat well, go for picnics, they enjoy, they do sports and all. So world over shift from split mix regime to basal bolus regime. Now this is a common thing. 4-time insulin is preferred. So from 2 year onwards, we are using only basal bolus regime unless patient is poor or in periphery. And glucose diary, it's the most important thing we have to give. So in that they have to write the sugar values, diet, exercise, and whenever they are coming to me, just like without hall ticket they cannot enter the exam hall, same way glucose diary, glucometer, and other, the emergency kit for type 1 diabetes. Emergency kit is they should keep the sugar packet or glucovita tablets or polo, so anytime they can go for hypoglycemia. So still DK remains the most common cause of readmission all over the world in type 1 diabetes. So concentrate on diet, exercise and psychology. So be preferably sent to dietitian and also psychologist whenever they diagnose first time and frequently. Blood ketone meters are replacing the ABG and urine ketones. Thank you very much. So
Thank you, Dr. Amannath. I think it was an excellent and a very pragmatic approach of management of the so-called sweet kits. I like that word. Probably I'm going to use it quite often from now onwards. I think we'll
yeah,
pick up the QA session after the second speaker's topic, Dr. Swaraj.
sure, sir. Sure, sir.
Yeah, I have the second speaker in the form of Dr. Swaraj. He is the chief consultant of endocrinology, Anugraha Diabetes Endocrinology Center, at and he is also an associate professor of medicine, MR Medical College, Kalaburgi. Has been the principal investigator for the lead trials and landmark, which is an ongoing trial. He has many awards, and precisely to state that the Best Paper Award at Bengaluru and Challenges in Diabetes in 2019 at Mumbai. And he has publications in the Medicine Update. So, JAPI, IJSR, and IJM. So, good work from Dr. Swaraj with regards to the
Thank
field
you.
of diabetes and endocrinology. But today he is going to enlighten us on the thyroid disorders complicating the pregnancy. Dr. Swaraj, I welcome you.
Thank you, sir. Thank you, sir. Thank you. I'm just waiting for the slides to connect. This always happens with me. I do take a little bit extra time compared to others when I'm trying to join the slides. Okay, I'm not able to do that.
So can you hear me?
Yes.
Open the PPT and then click on share screen.
Is it visible?
No, sir.
1 second.
So what do you see on your screen right now?
Right now, this application window, no, this isn't coming because I'm using another application on Edge. So, is that the reason why this is not coming?
No, sir. You should be able to share your screen. Do you have two devices
See,
close
basically what's
by?
happening is, no. See, when I click the share screen, what I see is the entire screen that is visible right now.
Do you see the options?
Your entire screen, application window, Microsoft Edge tablet.
Are you using a laptop or you're using a tablet?
Laptop. Laptop.
Your PPT is open and you're not able to see in share screen. Are you using a web version or a installed desktop?
Web version.
Okay.
So can you take control of this and do it?
So we will not be able to take control. Dr. Faraz, if you could, is there a possibility that you take the presentation for sir?
Yeah, definitely. Suraj, if you can share the presentation, if you can mail me, by that time we'll just have some discussion and 2 minutes you
Oh,
can start.
yes.
Uh, since it's taking, so it might take 2-3 minutes. I think, Dr. Srikanth, it would be nice if you can have some discussion with Dr. Amarnath for the benefit of the our fellow colleagues who are there. We'll just sort this out in another 2-3 minutes. You need to unmute. You need to unmute. Unmute.
Can you
Now
hear
we
me now?
now we are able to hear you.
Yeah. Dr. Amarnath, are you ready for the questions? Because it's going to take a little longer for Dr. Swaraj's presentation. I think he has gone out of vision. Dr. Amarnath is not to be seen. Dr. Faraz, I don't see Dr. Amarnath on the screen. Probably, I think he has just gone to take rest.
2 minutes, sir. And
No issues.
setting the things. Probably, sir, you can share your experiences with type 1 diabetes.
Being an internist, frankly speaking, I see less number of cases of type 1. But it was quite enlightening. I have few questions which I would like to ask at the end of the session because they're directly Dr. Amarnath's topic. He has dealt it very well, very pragmatic approach in handling. And with regards
One
to that, I
second.
have few questions. I think, yeah, he's back.
Sorry.
No issues, no issues. Dr. Amarnath, we decided to have the questions for you because Dr. Swaraj's presentation is getting a bit delayed.
I'm extremely sorry. A patient came from long this thing. Yeah, please.
Okay,
No
okay.
issues. We'll start. Yes, please
Yeah,
go ahead. I'm very happy. In fact, I wanted to take early so that I can just
sure.
end. Yeah.
Yeah.
So God has given boon to me now.
Oh,
Yes.
good. Shall we start?
First thing is
Are there any
please, please.
questions from the audience or should I start from my side?
Anything is
Okay,
start, sir.
Yeah,
We'll
you can go
make
I
it
ahead.
would get
fast.
started.
Yeah.
Dr. Amarnath, you are very practical in terms of management of the so-called sweet kits. But one of the important things which I thought was pertinent is regarding the afternoon dose, especially you are stressing on the basal bolus component, which no doubt it is an established regimen. But most of the kids, they have that so-called psychosocial element in taking the injection while they're attending the classes. What's your experience and take on this? And how do you handle such type of kits?
Exactly, sir. Suppose if I want to be healthy and fit, I will go to gym and have a weight bearing thing.
Okay.
So when you want to become healthy and you want more freedom, when other all my friends are eating more in the afternoon, carbohydrate based food. So I want to eat more. I want to have more freedom. So rather than restricted one. So when I take insulin, so it will be very easy and I can have a freedom. That's one thing. Second thing, we have a written plan for all school teachers. We will give the school teacher the written plan, and also we train them, so that makes easy. Usually the advanced schools, they have a nurse room or the special room where they take, otherwise they take in the bathroom or something, or with usually I tell to all school teachers are one of the friends, they will make very friendship and they will get. And already I said we keep either glucon D or some the polo tablets in the school also. And it's always better to carry glucometer for children who want to play more sports or something. So uh, we have to overcome ourselves. So we had lot of kids like that. So I will give one more alternate regime to you, what you are thinking, what is in your mind, I catch that. So some patients are they are more afraid. In those patients, what we do is 1 p.m. they take snack like thing, and evening 4 o'clock they take like lunch. So this only 10 to 20% of patient, but maximum patients we train them, we train the parents initially. Mother goes and gives in the school, and after 6 years of age, child himself will start taking the insulin pen. So it will become easy, and we give the kit which contain to carry the what we call the ice pack, so that it will be very easy for them. And I preferably give only pen in the afternoon dose. This is a very very important thing, because it's very easy. They can just adjust the dose and give, but taking the syringe and all, it's very difficult. So this is a very important issue, as you said, sir. But the freedom and the long run, if you take, if you're taking basal bolus regime, your lifespan is as normal as any other adults.
Correct.
So I can say 5 to 10 years it will increase. I have seen so many number of patients. Any patients who is having bad control, you start afternoon insulin, you see very good control. Any
Good.
other questions, sir?
Yeah. So the message is, rather than concealing the fact, it's better to convince by good counseling.
Exactly.
The second question, which I thought was pertinent again, is in the CV, it was mentioned that you have good bit experience in with regards to the use of pumps.
Yes,
What's your
sir.
take on the usage of insulin pumps in type 1 diabetics, and how many cases? Because I foresee a rapid increase in the coming decade. The usage of pens probably would be much more beneficial, and then it would almost
Yeah.
have.
Very good question, sir. I have at present five pump patients. So two of them are there shifted to UK and US. One of the patient came from US for post kidney transplant, BK virus, and tacrolimus induced diabetes. For that we have started, because that is a normal thing for in US and UK.
Correct.
Here it's a little rarer thing. So, but one thing I wanted to say is now most of them they are shifting from insulin pump to 4-time pen insulin. And recently I was also speaker for the pediatric diabetes update 2020, so which was by ISPAD, International Society for Pediatric and Adolescent Diabetes. Slowly the advanced without pain, the pens are coming. It will be introduced within a year or so also. So the definitely the insulin pens will replace the insulin pump.
Oh,
So,
that's
and
nice.
as you said, as you brought up the very important point for insulin pump. So all insulin pump patients, they have a backup of insulin pen. So when something is kinking, so this though is a very rare complication, they have backup of insulin pump and meter. So they have to stop the pump any failure and start taking the insulin injection. So otherwise, the cost varies from 1.5 to 5.5 lakhs is the advanced pump. So for 5.5 lakh, we have the remote control, easy. Now automated pumps have come, which can off automatically. The most advantageous thing in pump is we have a double wave or square wave bolus. They are taking like pizza. They are going for biryani. The square wave bolus. All those things can be given, which has got advantage. Advantage in insulin pump patient, we give 8 time insulin. Suppose he is taking morning just coffee or tea with biscuit, he will take 10 o'clock small snacks, we give insulin. So that's the advantage, more advantage is there. But one point as you brought up, they cannot have a freedom just like others. So all strict rules should be continued. Along with that, they have to follow this. Any other question, sir?
Thank you. There are the questions from the audience or Dr. Faraz and Dr.
Yeah, yeah. I think we have a few questions. So there is one question. It says, other than research, do antibody really help us in making a diagnosis in a 5-year child presenting with decay?
Exactly, excellent question. We are from very poor country. There is no role of antibodies. You have a clear-cut diagnosis. So when there is a weight loss, when there is a DKA, hmm, so insulin requirement in DKA is 2 to 3 units per kg per day. So DKA means there is a absolute insulin deficiency. Means 90% of loss is there. Without 90% loss of your insulin, DKA cannot happen. Rarely in type 2 diabetes, as I said, 5 to 10% of cases can present with diabetes. So if child is obese, yes, but usually 5 years child will not present like that. Adolescents can present. Even obese children with presenting as decay. So no role. So if they are affordable or they are eating your head, so they want to know what is a cause and all. For them we do. Otherwise no need.
The other
So
question is, yeah, yeah. Please finish. Sorry.
yeah. Yeah, that's the thing. So the important is by getting your antibodies, the treatment mode will not change. If you are thinking of Modi, yes, I will do. So means all sugars are in between 150 to 250, no high sugars. You are thinking of Modi, child is normal, obese, family history, 3 generation family history. You are thinking of Modi. There I will do. Yes. Any other
Yeah.
question?
So, what is the cost of ketone meter and its availability?
He has already mentioned.
Its cost is just 2000 to 2500 rupees. It's available from the about the stripped cost is 100 to 120 rupees. Another 2 3 companies are coming with 60 and 80 rupees, but that's not reliable. So Freestyle Libre meter is having both ketones and sugars. You can do in the same meter. That's the most advanced, best one. All of you can get.
Probably, I would ask one question to Dr. Swaraj, unlike from his topic, but he's done a lot of research on KPD. So, ketone prone diabetes is
Yes.
one where Dr. Swaraj has worked a lot. He has done, in fact, few publications as well. So, probably, Dr. Swaraj, you can keep your view on KPD, and when we can have Dr. Amarnath's view on that.
Yes, sure. KPD, I think in whatever research that we have done, we could see close to around 6 to 10%, although textbooks say the incidence is much higher. But what we could deduce from the little bit of experience what we have had is they are obese, unlike type 1 diabetic. That is the first thing. Second thing is they have severe acanthosis nigricans and skin tax, a clinical marker for severe insulin resistant. Second point. Third point is they will require a huge dose of insulin to begin with, both when the patient is on IV insulin. Second, when we do a transition from IV to subcute, and then over a period of 2 to 3 months, the requirement, which was let's say around 1.5 kg per body weight, will fall down to zero point 0.2 to zero point 0.3 per kg per body weight. And over a period of 2 to 3 months, we are definitely sure that we are going to stop. Hence, making a diagnosis of KPD is very important because that will tell us whether we should continue insulin, and we can also give hope to the patient. Yes, although you have presented with a severe insulin deficiency, we will continue this insulin for a short period of time, and it is not going to be lifelong. As sir was saying, never use the term. I also specifically never use the term lifelong in my clinical practice. It is till the requirement is there. So 2 to 3 months, take off insulin, patient happy, doctor happy, everybody is happy at the end of it.
Yeah, I think very, very well. And then I think this is few entities which all of us are learning day in and day out, new for all of us. And then it's always nice to hear it from people who have worked on the subject. Dr. Amanath, your view on that, and we would not keep you on holding. You can go back to your patients.
Yeah, thank you so much. As said, ketone-prone diabetes is there, but it's a new entity called LADA is coming back. I have lots of patients of late onset of adults diabetes with type 1. So we should keep this in mind. So because normally onset of type 1 diabetes it takes around 3 to 6 months, but in LADA it may take up to 18 months. So keep in that. So that's why the amount of ketones also important. So of course we should keep along with ketones acidosis, your family history, consider the BMI, obesity, all the things, and multi-system involvement. I said already I have seen 10 types of diabetes. So mitochondrial diabetes, FCPD, MODY, other syndromic, Didmot syndrome, lipoatrophic type of diabetes. So multi-systemic involvement. So what I say is go for multi-pronged approach, not only ketones, include all others. So it will be very easy to have diagnosis. So any other?
Thank you so much.
Thank you. Yeah.
I'm extremely sorry because of patient.
No, no,
So
no.
I'm very much grateful to Srikant sir, and Swaraj sir also knows my friend is working in MRMC, Dr. Kumar Angadi. So I'm grateful to all four of you, and we wish you all the best for your Gurukul. And kindly involve me. I wanted to take more question answer session rather than my teaching. What is their burning this thing? So again and again, my last take home message to the viewers is only one. That is, give maximum love and hope to them. Love and hope to them, and really you have to spend time with them and feel like their family, and start doing some camps for them, go with them, then you will enjoy a lot. Thank you very much. Bye.
Thank
Thank
you.
you. Thank you so much.
Yeah.
So now I think Dr. Swaraj will get back to the topic which you wanted to speak,
Yes.
and I had diverted it. So
So,
over to you, Dr.
okay.
Swaraj.
Okay, thank you, Faraz. I think I'm very, very thankful and grateful for you for giving me this opportunity. I was there at the launch of this event as well, in good times when there was no COVID. So from sweet kids, with the permission of the chair, I'd like to use a term probably many will not agree and some may take offense to it. From sweet kids to hot moms, that is where I will be going to. So thyroid physiology. So whenever we talk about thyroid and pregnancy, we have to talk about basically we need to understand the physiology first and then go for the other associated diseases. So what happens? So pregnancy is a natural stress for the thyroid gland. Hence, what are the basic changes that happen in our when a lady gets pregnant? So one is there is increase in the estrogen, similar structure of HCG and TSH. What do they do? This similar structure stimulates to release more amount of T3 and T4, and then there is a transient decrease of TSH somewhere in between 7 to 14 weeks. So if a lady who is pregnant comes with a TSH of let's say around 0.04, with no thyroid disease in the family, no prior thyroid disease, so suddenly we should not make a diagnosis of saying that the patient is having hyperthyroidism. So normally in pregnancy, what happens is your T3 and T4 are elevated. We take roughly around, if we take a normal upper reference range of 12 for T4, up to 18 or 20 can be taken as a normal T4 of pregnancy. So first trimester pregnant lady coming to you with a TSH of 0.04, 0.05, 0.06, suppress the TSH with normal FT4, we need not have to jump and start the treatment. So we just have to wait and watch for around 4 to 6 weeks, and then we can take further call. Also, if that T4 is let's say around 22, 23, 24, plus the patient is presenting with severe weight loss and eye symptoms and cachextic look, so that is when we think of other causes, like for example Graves' disease or any toxic nodule causing hyperthyroidism in pregnancy. So these are the two things that we need to consider. Then what happens? There is an increase in the peripheral metabolism of thyroid hormones that causes decreased FT3 and FT4. So hence the demand for T3 and T4 goes up by 30 to 50%. This is again the basic physiology. For example, somebody who's pregnant, she is somebody who is not pregnant, she's taking levothyroxine of 100, suddenly, I mean not suddenly, gets pregnant, and then she comes to you with a TSH of 1.5. Even then we are supposed to increase the dose by around 30 to 50%. So what are the effects of HCG on thyroid function? There is a structural homology between HCG and TSH. HCG may act as a thyrotropic agonist by overlapping of their natural functions. Normal pregnancy, the direct stimulatory effect of HCG on thyrocytes induces a small but transient increase in FT4 near the end of the first trimester, and in turn a partial suppression. So this doesn't require any treatment. Waitful watching. As you can see, as the TSH, as the HCG rises, the TSH decreases. So hence, no need to treat again. Next slide, please. So prevalence of hypothyroidism, this was done by all the renowned endocrinologists across the country. So what they did was they tried to have a cutoff level. So to see what happens to the hypothyroidism in pregnancy at various cutoff levels. So for example, if we take a TSH cutoff of around 4 to 5%, sorry, for TSH cutoff of 4.5, we get 15% of the patients who are hypothyroid. But if we use cutoff of 2.5 or 3, the incidence or the prevalence increases by almost 3 times. As you can see, same with first, second, and third trimester. As and when the TSH cutoff is decreased, yeah, we are going to miss a lot of patients with hypothyroidism. Next, please. So screening for thyroid disorders in pregnancy, what are the tests that we do? I specifically follow TSH and FT4, at least initially for diagnosis. And then once the patient is on follow-up, you can just use TSH as a screening or for monitoring your treatment. So by what are the study designs and sample sizes across the various countries, whatever they did. So TSH of 4, 81.6% of the patients were missed with hypothyroidism with pregnancy. That is when the TSH was more than 4. So when it was more than 2.5, 46%. Again, same thing with respect to all the other studies. So this is again a burning topic. 2.5 to 4 is a shade of gray, whereas more than 4, at least now more than 4.2, just start treatment. There's absolutely no need to have any confusions. So a TSH of more than 4.2 in the first trimester of pregnancy requires treatment. That is as simple as that. Next, please. So has shown that this case-based screening can miss close to around. So basically, with this approach, we miss 1 in 2 patients with hypothyroidism, and that can have adverse effects. Next, please. Next, please. Next, please. So ITS, that is the Indian Thyroid Society, and the FOXI 2019 recommendation for management of thyroid dysfunction in pregnancy. All pregnant females should be screened at first antenatal visit, irrespective of whether they are having thyroid disease or no. You are supposed to do a screening test. So what is the cutoff that they have come to? So first trimester 2.5, second trimester and third trimester it is 3, and this is across various the ITS, ATA. ATA is being a little diplomatic, saying that you have to use the locally available, but usually in India we don't have any local data. So for all practical purpose, we use TSH of more than 4 as a subclinical hypothyroidism in pregnancy. Next, please. So ITS and FOXI recommendations for the management of thyroid dysfunction in pregnancy, same thing. Next, please. So hypothyroidism in pregnancy, what are the implications for the mother, for the fetus, as well as for the newborn? So what happens if we do not control? Anemia, congestive cardiac failure, preeclampsia, placental abnormalities, low birth weight infants, postpartum hemorrhage, and myopathy. These are all the maternal risk associated with untreated hypothyroidism in pregnancy. What happens to the fetus? Cognitive impairment, neurological abnormalities, developmental abnormalities, congenital hypothyroidism. What happens to the newly born? Respiratory distress and hyperbilirubinemia. So all this can lead to can have an adverse impact on the mother as well as the baby. Hence, it is very important for us to treat the pregnant ladies with hypothyroidism. overt and subclinical thyroid dysfunction among Indian patients. As you can see, the controls had higher risk associated with anemia, PIH, GD, IUGR, and intrauterine death. Hence, it is imperative on us to make sure that, because it is a simple, safe, easy, and cheap treatment which can give very, very good results. So we should not be missing subclinical hypothyroidism in pregnancy and otherwise. Same thing with respect to the perinatal outcomes. All the adverse events were higher in the control group than compared to the study groups. Subclinical hypothyroidism. So pregnancies in women with subclinical hypothyroidism were 3 times more likely to be complicated with the placental abruption. Preterm birth was almost 2-fold higher in women with subclinical hypothyroidism. So more or less the same complications that we see in overt hypothyroidism are also seen in subclinical hypothyroidism, easily correctable. Hence, we should make sure that we do not miss a very simple and easy to treat disease. Next, please. So effect of LT4 on pregnancy loss rate and preterm birth rate among pregnant women with subclinical hypothyroidism. TSH of 2.5 to 4 with a TPO negative, anti-TPO negative, no significant difference in preterm delivery. So this again, as I was saying, this is a gray window where 2.5 to 4 we are not able to make any decisions. So in such cases we do anti-TPO, and if that anti-TPO is positive, we treat. Whereas in a patient who is having a TSH of more than 4 but is anti-TPO negative, then there is significantly lower risk of preterm delivery in the levothyroxine treated group. Next, please. Next, please. So during pregnancy, all the patients who are TSH is more than 2.5 should be treated. For overt hypothyroidism, the dose is 1.6 to 2 micrograms per kg body weight. Maintain a target of TSH of less than 2.5. Patients with pre-existing, as I was telling you, because of the normal physiological changes in pregnancy, the levothyroxine requirement in pregnancy increases by around 30 to 50%. So somebody who's taking 100, you can make it 125, irrespective of whether the TSH is normal or even if the TSH is in between the reference range of less than 2.5. So if, for example, if a pregnant lady comes with a TSH of 6 and she was taking 100, you can very conveniently make it 125 daily and add a double dose on the weekend. So where do we recommend levothyroxine therapy? TSH greater than 4, TPO positive with a patient, TPO positive in a patient who is having a TSH between 4 and 10. LT4 can be considered for TPO negative women between 4 and 10, TPO positive women between 2.5 to 4. This last point is very, very important. Where we were having the gray zones, now it is becoming clearer and clearer. For example, 5 years before, 2015-14, we were not very sure, but now there is enough hard evidence to say that yes, even if the TSH is 3.5 in the first trimester, you are supposed to treat. Next, please. So postpartum in patients with pre-existing hypothyroidism, post-delivery, the patient should be reverted back to the pre-pregnant dose. This is very important. If you are taking 100 before the pregnancy, you have been made 125 and 150 till the end of pregnancy, you can directly go back to your pre-pregnancy dose. Some women on whom the levothyroxine is initiated during pregnancy may not require levothyroxine postpartum. Usually this happens in subclinical hypothyroidism. So such candidates, if the patient is taking a dose which is less than 50 micrograms per day, you can directly stop the medicine post-delivery, repeat a TSH after 6 weeks, and then based on their TSH level, then further decide. Another thing to keep in mind in such patients is something called as postpartum thyroiditis, usually which happens around 4 to 6 months post-delivery. Next, please. This is again another burning topic, euthyroid pregnant women with thyroid antibodies. This is again a gray zone. We still don't have any data. So what we usually say is, if the TSH is less than 2.5 and anti-TPO positive, no need to treat. We can wait and watch. Whereas if the TSH is between 2.5 to 4, anti-TPO positive, then we are supposed to treat. Next, please. Next, please. Next, please. We have already discussed this, so this is more of a revision. So ITS and FOXI recommendations for the management of thyroid dysfunction in pregnancy: euthyroid pregnant women with thyroid autoimmunity, women with thyroid autoimmunity who are euthyroid in the early stages of pregnancy are at risk of developing hypothyroidism and should be monitored with TSH at least once in every trimester, at least up to the end of second trimester. So it is again, this is an expert opinion and not a hard data that is based on evidence.
Cell-T4 therapy can be considered, very important, need not be given to all, can be considered in euthyroid pregnant women with thyroid positive antibody and with a history of pregnancy loss. Again, no, not a hard data to go all out and say yes, take it. Hyperthyroidism in pregnancy, which is again a very rare presentation, which complicates around 0.05 to 0.2% of the pregnancies, of which Graves' disease is the most commonest. Subclinical has a prevalence of around 1.7%. Again, we don't treat subclinical hyperthyroidism in pregnancy because naturally also the body is designed so that we want the FT4 to be in the higher normal range, whereas the TSH to be in the lower normal range. It is often associated with increased HCG levels in pregnancy. Hyperemesis gravidarum seems to be associated with subclinical hyperthyroidism, but both of them do not require significant treatment. They can be monitored and then decided whether to treat or not. Effect of pregnancy on Graves' disease, symptoms are aggravated during the first trimester due to increased HCG production. Thyrotoxicosis improves. This is very, very important. If we take trimester wise, the first trimester, most of them will require medicines. As and when the pregnancy progresses, we see that the requirement of antithyroid medicines comes down. And I have around, at least up until now, I have seen around 40-45 cases of Graves' disease with pregnancy. In around 70% of them, we are able to stop the medicines at the end of around 6 months of pregnancy. So as and when the pregnancy advances, we are able to stop the antithyroid medicines. This is because reduction of TSHR receptor stimulating antibody levels during pregnancy improves the symptoms of Graves' disease as well as the biochemical presentation. Postpartum symptoms increase due to the sudden rise of TSH receptor and stimulating antibodies. Next, please. So obstetric and medical complications are directly related to control of maternal hyperthyroidism and the duration of euthyroid state throughout pregnancy. Poor control of thyrotoxicosis is associated with pregnancy loss, pregnancy-induced hypertension, prematurity, low birth weight, IUGR, stillbirth. Thyroid storm is a little too rare, and maternal congestive heart failure. Next, please. So again, whenever we treat a patient who is pregnant with any drugs for that matter, we think about two lives. One is the mother, the other is the baby. So in pregnancy, what comes more is, if you ask the mother, she'll say, nothing should happen to my kid. So what are the various congenital anomalies that have been previously reported with methimazole or carbimazole? So we have aplasia cutis, corneal atresia, trichoesophageal fistula, patent vitreointestinal duct, esophageal atresia, omphalocele. Again, these are very, very rare. Ventricular septal defects, dysmorphic features, nipple abnormalities, developmental delay, deafness, and retinal coloboma. These are extremely rare, seen in less than 1% of the patients who are exposed to this disease, this drug during their pregnancy. Next, please. Same thing confirmed by the Danish nationwide study. Next, please. Next, please. So conclusion is methimazole use in early pregnancy were associated with increased prevalence of birth defects, which was more with respect to methimazole and carbimazole. And hence, we say that if a patient is diagnosed, if the patient comes to you with pregnancy and she is on methimazole, you are supposed to change the drug from methimazole to PTU or propyl thiouracil. Use of ATD in early pregnancy should be limited. So, for example, if you are starting the dose or let's say around 20 milligram of methimazole in a normal patient, in a non-pregnant patient, you start at a much lower dose. You can start at 50% of that dose. It may be optimal to shift to methimazole to PTU before pregnancy starts, but that is a little again dicey. Next, please. So maternal hyperthyroidism, the ITS and the FOXI 2019 guidelines, they recommend treatment for overt hyperthyroidism diagnosed during pregnancy. Thyranoids are the treatment of choice. PTU is recommended in the first trimester, followed by a switch to methimazole at the beginning of the second trimester. In women on low dose of methimazole or PTU, ATD must be stopped. Such patients should be monitored every 2 weeks to assess maternal and fetal thyroid status. Next, please. So when ATDs fail to control the hyperthyroid disease, second trimester is the safest time for surgery. This is again very, very rare. I have seen only one patient up until in my 10 years of my practice where we had to do a surgery because the mother was not being controlled with ATDs. So what we generally say is high dose requirement to maintain euthyroidism, plus some patients may have a drug allergy, especially to methimazole. So such patients will require surgery. As we all know, radioiodine ablation is contraindicated in pregnancy as well as in postpartum period. Next, please. So so if the mother is euthyroid but tests positive for TRAB, there is a possibility of fetal thyrotoxicosis, that fetal heart rate of more than 160 beats per minute. If all other causes of fetal tachycardia are ruled out, start the mother on methimazole carbimazole to control fetal thyrotoxicosis and this is the block and replace therapy, which we usually do not practice nowadays, but this is one indication in pregnancy where we can start block and replace therapy. Does not warrant subclinical hyperthyroidism, no treatment is required. So again, a rare entity, because usually we do not see much of such cases in pregnancy. And if the patient is euthyroid and a thyroid nodule, we do not do anything till the end of pregnancy. Plan for a management of such disease post the delivery. Pregnancy is associated with growth of pre-existing thyroid nodules as well as the growth of new nodules. Most palpated nodules of the thyroid are benign, and however 5 to 20% are true neoplasms, benign adenomas or carcinomas. The approach in a pregnant woman with a palpable thyroid nodule is similar to that in a non-pregnant woman and includes a serum TSH and an ultrasound to measure the volume of the gland, the calcifications, the halo, and the blood supply. Next, please. So pregnant women with palpable thyroid nodule should be evaluated by measuring TSH and an ultrasound assessment of the neck of the thyroid gland and an FNAC. If the nodule is malignant or shows rapid growth, consider surgery in the second trimester. If the nodule is benign, no further evaluation is needed. Levothyroxine is given to normalize TSH and follow up of with the USG and TSH later. So we usually do not do anything unless until there's a big goiter or big nodule which is suppressing the surrounding structures like the trachea or the esophagus, or if the patient is having any other symptoms like hoarseness of voice, that is when we go for surgery, or else usually benign nodules we do not do anything. Next, please. These are all again rare presentations. In case of papillary or follicular thyroid cancer, suppression therapy should be initiated to maintain a serum TSH levels in between 0.1 to 0.8 for patients with, and it should be less than 2.5 for patients with medullary carcinoma of thyroid. If the size of the nodule is stable, repeat biopsy should be performed after delivery. Post-surgically, patients should be maintained on levothyroxine therapy to monitor TSH and FT4 levels every 6 weeks. This another important point I would like to stress is, if a patient is having papillary carcinoma of thyroid, the TSH levels are much less, as mentioned here, 0.1 to 0.8, and it should not be 0.5 to 4 or 0.5 to 5 that we usually keep in and otherwise non-malignant cases. So the TSH should remain suppressed because the growth is dependent on the TSH. Post-surgical whole body scintigraphy and radioiodine remnant ablation are contraindicated during pregnancy and lactation. Next, please. So I think I tried to cover most of it because the subclinical hypothyroidism itself is a big talk to talk on. In this half an hour, 40 minutes, I have to put on multiple things. So I think I've tried to do the best that I can do. Also, the importance of this thyroid disorders in pregnancy is, to say from my personal experience in the past 2 weeks, is this is my 5th talk on thyroid disorders in pregnancy in the past 2 weeks. So that is the kind of importance that this disease has. Thank you, Faraz, and thank you, Shrikant sir, for coming and spending your Saturday night with us. Thank you. Faraz has to give us a treat for all of us.
Oh yes,
We have to
now-
give. We have to give to Dr. Faraj for organizing a wonderful event. Dr. Swaraj, I think it was quite an elaborate version of what you have spoken. Very clear, lot of clarity in your topic and discussion. And I would open up the questions. For a change, I want the audience to get started, because it would be unfair if I keep talking.
Yeah, there's a chat box where you can post in your questions. We will take it from there. So I think once they start putting the questions, in the meantime, Swaraj, I know you spoke about the importance of subclinical hypothyroidism. So now, see, again, that gray area is always very much debatable, where we always have a lot of talks on that, and our gynae colleagues are never satisfied with whatever answers we give. So, subclinical, is there a specific definition for subclinical hypothyroidism in pregnancy?
See, yeah, otherwise, let us talk about non-pregnancy. In non-pregnant, what we usually say is a TSH between 4 to 9.9 is subclinical hypothyroidism. And in pregnancy, the level is pushed down to 2.5. So somebody's TSH is more than, let us assume it is 3.2, lady is 6 weeks pregnant. She doesn't have a history of thyroid illness in the family. She has a goiter. But goiter can be there even in a normal individual with a TSH of less of 1.5 because the thyroid volume increases in pregnancy. So goiter will not become an indicator to start treatment in this lady. So what we usually say is it is a biochemical diagnosis. So any TSH of more than 2.5, treat. There's no harm. And anyways, we are not going to give a, like, for somebody who with a TSH of 3.2, we will not give levothyroxine of 100 or 150. We will be starting with 12.5 or 25. So that will not harm. And normal physiology of pregnancy also teaches us that the TSH is suppressed and the FT4 or the T3, T4 are on the higher levels. So if it is not in that way, that means basically there is some amount of compensation which has to happen, has not happened in the body. So we are going to treat it. So I personally, in my practice, TSH of 3.1 or 3.2 in pregnancy with anti-TPO positive, I treat. I err on the side of caution rather than not treating the patient.
Dr. Swaraj,
Sir.
I have a question for you.
Sir.
As an extension with regards to the complications which you have mentioned,
yes,
what is your experience in dealing with the fetal thyroid disorders, and what is the incidence of fetal thyroid disorders in an already established pregnant woman with a thyroid problem?
Sir, to begin with, a pregnant lady with hypothyroidism usually will not have any poor fetal outcomes if she is well maintained. For example, the same thing is not true for a patient who is hyperthyroid. So we can see a fetal goiter, we can see tachycardia, plus those corneal atresia, aplasia cutis, because we have to treat. It's not that we are not going to treat a pregnant lady with hypothyroidism. So in such cases, it becomes a little difficult. And in our center, we have a pediatric endocrinologist, so that they don't let me near the neonate. So my experience with pediatric neonate or neonatology endocrine disorders is very limited.
Because quite often my wife is a fetal medicine consultant.
Oh, okay,
so she handles these cases of fetal goiters, and then I quite often see her giving intrauterine IV infusions of thyroxine to manage the goiters. So
okay,
that's
are these patients on any anti-thyroid medicine, sir, or is it like for whom do they give this
few of them? Yeah, few of them. Yeah.
Okay. Okay. As a tertiary level center, so it can be managed easily, not in our place.
But it is an interesting area to work upon.
Yes. No doubt, sir.
So, Dr. Swaraj, there's one question which has come up. It says that you mentioned that the start, suppose if you're diagnosing someone with hypothyroidism, frank hypothyroidism, say consider TSH, I would make it as a question, practical question. TSH of say 9.5, you have diagnosed for the first time during pregnancy. So the question is, you have mentioned from 1.5 to 2 or 2.5 micrograms per kg per day is the dose what you have to start. So they want to ask, do you start with 100, 150 directly, considering the way?
Yes, 100%. There's absolutely no doubt about it. For example, let us say a pregnant lady who's 55 kgs. She is in third trimester. She is in first trimester. Because in India they come around at 8 to 10 weeks of pregnancy. They don't come at 6 weeks as they do in Western countries. So a 10-week pregnant lady with a TSH of 9 with a weight of 55 kgs, 100 is the dose. Actually, we can go up to 125 because the dose is 1.8 to 2.4 microgram per kg body weight. So start slow. You make it around 100 or 2 micrograms per kg body weight. Then gradually see. You are not going to harm the pregnant lady whose TSH is on the higher side with levothyroxine. So that is if we are, and there are no side effects. For example, the atrial fibrillation, osteoporosis, and all the things that we worry about, those are in non-pregnant patients, elderly patients, and who have been exposed to this drug for a prolonged period of time. In pregnancy is a 9 months period. They have come already 2 months later. I mean 2 weeks later. So you have a window of only around 7 months to treat. So that will not cause any side effects to the mother or the child.
And then there's another question: how frequently would you monitor this patient, and by what parameters?
Uh, at diagnosis, TSH and FT4, it again depends on the area where we practice and the kind of lab backup that you have. So, example, I do a TSH and FT4 in the first 2 trimesters, and then only TSH in the last trimester. Monitoring depends upon their control. 4 to 6 weeks for the first 2 visits, and then 8 weeks because of their cost, availability, travel, so many things that we need to consider. So, 4 to 6 weeks, first couple of times, and then 8 weeks follow up, and then first 2 visits TSH and FT4, and then only TSH.
There is again an interesting question. Again, I think so. Is there any role of free T3 monitoring of free T3 in pregnancy?
Rarely, yes. There is one entity called as I mean, in hypothyroidism, no.
No.
In hypothyroidism, no. But in rarely we see patients. There's one entity called as T3 toxicosis. So I have around 3 patients where their FT4 is on the normal side or the higher normal. TSH is suppressed, but only FT3 is elevated. So that is called as T3 toxicosis. So very, very rare. Not generally, we do not do FT3 in the routine practice.
Yeah, I think clinically this is where it becomes very, very interesting. Sometimes you have a suppressed TSH, and as a routine, we all do free T4 levels, and then that is normal. But still, that patient is having that thyrotoxicosis features, presenting to you with a lot of increased heart rate, palpitations, and all. So I think here, yes, this point is very valid, that if we have somebody who is having a suppressed TSH and a free T4 normal, but patient clinically is having features of thyrotoxicosis, I think, as you said, free T3 would be required to do to rule out an isolated T3 toxicosis. I think that is again one thing which we may forget. And then probably my question would be a little different from pregnancy. How do you, treatment of secondary hypothyroidism? I think this is one entity which is less discussed, I know, but can you throw some light on that?
Secondary hypothyroidism, usually you're talking in terms of diagnosis or monitoring?
I think how do you diagnose and treat? I think both will be useful for the colleagues.
Diagnosis of secondary hypothyroidism, I think I have around 8 or 10, probably 12 cases of secondary hypothyroidism with me who are on follow-up for the past 3 years with me. So the first thing is very, very important. What is the clinical presentation? For example, I'll give you an example of a young lady around 20 years. She had an IUD at 8 months of gestation, and they took some home remedies and went. Then the patient came back to me in shock. So what actually it came to the hospital in shock, was managed conservatively. They went discharged against medical advice, and then at their home place somebody did a T3 T4 TSH. TSH is 4.2, T3 is less than 2, T4 is less than 1. TSH is 4.2. So what we usually see is when the T3 T4 are very, very low, TSH should shoot up. So that had not happened. So this is a clinical marker: normal or low normal T3 T4 with a quite normal TSH. So a normal TSH doesn't rule out a thyroid disease. So it is here where we have to do a T3 and T4 or the whole panel, or you do FT3 FT4 as well. That is one case. Second case was around a 60-year-old lady who had been visiting multiple doctors because of puffiness of face. She did not have any other complaints. So 10 times the TSH have been done in the past 3 years for her, and only twice was the T3 T4. Now, both T3 T4 were on the lower side. TSH was 2.3. So this is again a marker for looking at the hypothalamus or the pituitary to look for secondary causes. In both of these patients, the cortisol was low. The first case was a Sheehan syndrome. Second case was an empty sella syndrome. So this is very important for us to realize that a normal TSH does not rule out your thyroid disease. It
Okay.
rules out primary hypothyroidism. It doesn't rule out secondary hypothyroidism. So this is my clinical experience. That two cases that come to my mind. The other 10 I don't remember now.
Yeah, I think very well said. I think yes. As postgraduates, Srikanth sir would agree that in Usmania, we used to get calls, a lot of calls, even when we were there. We used to get calls from our government maternity nursing home where we used to see cases like this, where
Yeah.
patients used to come with shock. And then yes, probably we were that was our early days. It was difficult for us to identify and diagnose also that what is going on, why the patient is in profuse shock. But yes, we
Yes.
realized. And then I think here can you throw some light on when you're doing replacement therapy for this partial or complete hypopit, where you are giving thyroxine and steroid, so which should be given first and then which should be given second, and why?
Especially if I talk about the interaction between thyroxine and cortisol in a patient who is grossly secondary adrenal failure or secondary thyroid failure or secondary hypopet, it is very imperative for us to replace steroids first
Yes.
and then give the levothyroxine, because if you give levothyroxine first, levothyroxine accelerates the metabolism of cortisol and washes away whatever little cortisol the patient is having. So the patient will not respond to the treatment as well. So replace the steroids first and then give the levothyroxine. That will be the order. And then you give the reproductive hormones like the estrogen and the progesterone. Plus later, if the patient is affordable, growth hormones. Calcium should never be missed. Calcium and vitamin D. Vitamin D, especially, that is the most neglected part. So we give growth hormone, we give estrogen, progesterone, we give levothyroxine, cortisol, calcium, and vitamin D. We do miss sometimes, so that should not be missed. So this is my order. First is cortisol, levothyroxine, estrogen, progesterone, growth hormone, and then calcium and vitamin D continues.
Yeah, I think very well placed and said, which becomes very, very important because otherwise you may do bad to your patient. They may go into adrenal crisis. So
Yes.
there is one question which has come. They are saying that if a patient has been diagnosed with thyroid disorder during pregnancy for the first time, antibodies are negative. So what do you do after? So there was a discussion in your slide where you said probably that you can stop and see whether if the patient still requires the therapy. So what are the kind of patients where you want to stop the therapy and see? Because I think all of us get this question, Dr. Srikanth and you and
Yes,
me.
yes.
If they get the they say they just come to you and tell ki aap thyroid pregnancy के बाद चला जाएगा. So I think this is the question which we get day in and day out. So your views on
Yeah.
that and which type of patients you want to select?
Thyroid anti-TPO positive. Let us categorize these patients into two zones. One is anti-TPO positive, anti-TPO negative. Anti-TPO positive, less chances of stopping the medicines. Again, it depends on their initial TSH. For example, TSH was 3.2, 3.3, 3.4, or less than 3.5. Then you can give some hope. Yeah, yes, over a period of around 6 months to 1 year, we may stop your levothyroxine post-delivery, unless until you don't have a postpartum thyroiditis. So these are the patients who are less likely to go in for postpartum, less likely to be
On
dependent
supplement.
on levothyroxine. So TSH, anti-TPO positive, lower TSH in the sense in terms of their TSH of 3 to 4 or 3 to 5. So these are the patients who are less likely to be dependent on levothyroxine. One. Second is anti-TPO negative, TSH of 4 at diagnosis. So then you can, and the requirement in pregnancy was never more than 50 micrograms throughout the pregnancy. So in them you stop it. Post delivery, immediately you stop. 6 to 8 weeks post delivery, you check a TSH in the normal range, then monitor every 6 months to 1 year depending on the patient's condition. Similarly, anti-TPO positive, TSH is around 8 or 9 or 10. Then very, very unlikely that these patients are going to stop the medicines. Also, anti-TPO negative, TSH in the higher quartile of 8, 9, 10 or 11 or 12. And then these are again question mark. Give it for around 6 to 8 months, see the response. They may or may not go in for postpartum thyroiditis and then take a further call.
Dr. Srikanth, sir, your views on that? Anything which you want to add with
No,
your
I
vast
totally
experience?
agree. Yeah, I totally agree with Dr. Swaraj's ways of management, especially with regards to the postpartum management, with regards to the antibodies. And I have the experience of just like Dr. Swaraj regarding the Shehans, two cases which came in frank shock, and then we had to diagnose them, myself along with Dr. Ravi Mehrotra. So we managed those two cases. Classical case of secondary hypothyroidism, in fact, hypopit. So very confusing in the office, and you need to spend time in making the diagnosis and then be alert to look into the soft signs and symptoms.
So, I think we don't have any more questions. So over to you, Dr. Srikant, sir.
It was a real pleasure, Dr. Faraz. This evening was really good in the sense both the topics are extremely important and then very dear to me. And Dr. Amarnath was very pragmatic in terms of the handling. And Dr. Swaraj, full kudos to you because you have dealt this topic, which is, I feel that very complicated one, and often ignored by the so-called physicians during their routine practice. And one needs to be constantly on the lookout. So, excellent work, sir.
Thank you, sir. Thank you. Means a lot. Thank you, sir.
Yeah. And keep going. Dr. Faraz, great
Thank you.
job.
Thank you. Thank you so much, sir.
And then it was wonderful to be amongst you people. And
Thank
I
you.
promise that I would be with you once again.
Thank you. Thank you so much, sir.
Thank you.
So at the end, let me thank you, Dr. Srikant, sir, for taking out your time and joining us for this very important debate discussion on thyroid and type 1 diabetes. And thanks to Dr. Amarnath. He's not there, but yes, a very thank to him as well. And then thank you so much, Dr. Swaraj. You have,
Sir,
yes,
my pleasure, sir. My pleasure.
you have always been a part of our team. So thank you. And then thank you everyone for joining us today for this closure of this year's Gurukul Scientific Update. Thank you so much.